Welcome everybody, and for you who don't know me, my name is Svetlana Sinipostolova. I'm a health and menopause coach, and I'm coaching women over 40 who is transitioning from perimenopause, menopause to postmenopause, and I'm perimenopausal myself, so I understand exactly what are you going through. Also, I am pelvic floor trainer, and I'm the host of my Facebook group, which called Women's Intimate Health and Sexuality, where I share my knowledge and my expertise and my opinion on perimenopause, menopause, and postmenopause, and all other stuff, including all areas of women's health. Today, my honored guest is Michelle Jacobson. So I'll read the everything in the introduction because it's so much for me. So Dr. Michelle Jacobson is a Canadian gynecologic oncologist and surgeon. She specializes in breast and ovarian cancer and complex issues related to women's hormonal health. She is the director of the Familial Ovarian Cancer Clinic at Mount Sinai Hospital in Toronto, and associate professor in the Department of Obstetrics and Gynecology at the University of Toronto. Dr. Jacobson is also a staff physician in the Department of Gynecology at Women's College Hospital, affiliated with the University of Toronto. Her clinical and research focus is on menopause, cancer survivorship, and hormone replacement therapy for women with elevated genetic risk, such as breast cancer. Dr. Jacobson has contributed to national and international guidelines and is published in leading journals, including Gynecologic Oncology, Journal of Clinical Oncology, and Menopause. She is known for her balanced, evidence-based approach to managing menopause, especially in women with cancer histories. Welcome, Dr. Jacobson. I'm so thrilled to have you here.
I'm going to correct you very briefly. I'm not actually an oncologist. I'm a menopause specialist and a gynecologist. So I share a lot of patients with my oncology colleagues, but I'm not an actual oncologist.
Okay, that's fair enough. Your expertise is more than enough for us.
Thank you.
So before we start answering all the questions I've got, because I've got so many, it's overwhelming. I want you to help me to debunk the myth about hormones that are harmful, especially after this 2002 Women's Health Initiative research, which was published in 2002. So there was a misrepresented meaning of this research. So from that, for 20 years, doctors and patients all together, they are afraid of using hormones. Doctors to prescribe them and patients to have any complications of it. So what's your opinion on that?
That's a great question. Hormones are such a broad category and they could refer to so many different things. It's obviously not appropriate to say hormones cause cancer or hormones don't cause cancer, because one hormone might do something and another hormone might do something else. What's important is to understand the overall effects of different hormones when you use them by medication or exogenously. And what we need in order to understand that are good quality research studies. Now, the Women's Health Initiative, which is the study that was published in 2002, is the largest randomized control trial looking at menopause that has ever been done. And it was actually done very well from the perspective of its research sort of standards. It was a well-performed study. The problem was, when we take results from that study and we apply them to our patient populations, we always have to ask ourselves, was the group of women who were studied the same type of people that we're seeing in our clinics talking about menopause with? And the way that those results were published was in a way that was very sensational and very trying to make people afraid, or publish information in a way that makes it sound maybe more grand than it actually is. So the important takeaways from the WHI were, first of all, these are not the only hormones that we use. The hormones that were used in the WHI was conjugated estrogen, which is an oral estrogen that's made from pregnant horse urine and is not the same estrogen as our ovary produces. It can be good in many circumstances, and it can have negative effects in many circumstances. And the type of progestin that was used was called medroxyprogesterone acetate.
Yes.
And this is a synthetic progestin that overall can be, again, valuable in certain areas, but in many areas it is actually more harmful, such as for the breast, such as for the risk of getting a blood clot in the legs or the lungs. Furthermore, the study was done in order to determine, do hormones help with cardiac events and heart disease and all of the other things looking like breast cancer were really looked at as secondary outcomes. But what this means is that the group of women they wanted to study were actually older women. So these are women on average who were 63 years of age, who were
Yes.
started on hormones for the first time, and the hormones that we don't really use a lot of anymore, to see what happens when we give these women hormones from a cardiac perspective. Obviously, that's not the same as I have a 48-year-old who's having irregular periods and suffering from menopause symptoms. And in fact, when they divided the results of that study by age into women 50 to 59, 60 to 69, 70 plus, they saw very different results based on age, where younger people had very good outcomes from starting hormone therapy and older women had worse outcomes. And this is sort of the part and the nuance that was not well presented to the public and to physicians.
Okay, thank you so much. And so in that study, the window opportunity for taking the hormones were more shifted to the older women. So, and it's not correlated with the younger women who might not have any complications after that, right?
Yeah, so what came out of the WHI study was the hypothesis called the window of opportunity hypothesis. And that means that when women have estrogen, it keeps their blood vessels clean and open because the estrogen acts kind of as a chimney sweep. It keeps the vessels clean. And when the estrogen goes away, you start to get opportunities for plaques to being built up and atherosclerosis to be built up within the blood vessels. And if you then introduce estrogen later, it again induces these proteins that act as chimney sweeps and breaks off little pieces of plaque and sends them to block the heart vessels or block the blood vessels going to the brain, causing heart and stroke and blood clots. But for the younger women who were 50 to 59, they didn't find that there was an elevated risk of heart attacks and of stroke because those women were within 10 years of their final period and hadn't had the window of risk to develop for atherosclerosis. So the window of opportunity is starting estrogen within 10 years of your final period or being under 60 years of age.
Okay, thank you so much for answering that. Because I am also have lots of questions. How old can I be to start hormone replacement therapy? Or how long should I take it? So if you can a little bit describe more. So is it for lifetime alone, or should be taken in a periods, or breaks should be taken? So how will you take it?
Yeah, so ideally, if you're taking menopausal hormone therapy, you're taking it in order to treat symptoms of menopause. And the most common symptom of menopause is hot flashes and night sweats, or vasomotor symptoms. And on average, these will last 5 to 7 years in most women, and they tend to be clustered around the time of when the final menstrual period would be. So if women are only taking hormone therapy for the treatment of vasomotor symptoms, on average, they would take it kind of around 5 years. That doesn't mean they have to come off of it at 5 years, but we do see certain risks, like the risk of breast cancer with certain hormone therapies, start to increase beyond the 5-year period. And we also know that as women age, they also have higher risks of developing cancers like breast cancer, but also of developing a blood clot, which is something you're at risk for if you're taking certain regimens of estrogen and progestin therapy. So we want you to take hormones if you need it for symptom management, but we don't want you to take hormones longer than you need it just because you want to take them. Everyone should be able to take hormones as long as they need it because it's providing them some benefit, but they also have to understand what the risks are so they can make that informed decision.
Okay, thank you so much. And regarding that, so hormones are not only for managing symptoms, they are promoting the lifestyle, the health, the bone. So they are affecting all our systems in the body. So cardiovascular system, our mental system, reproduction, whatever, gastrointestinal tract. So when we are taking hormones longer, will they not promote, but help us to sustain the health results, which are, so it won't be, well, it's hard for me to combine in the words. So they are preventing those old age diseases like heart attacks, brain fogs, Alzheimer, whatever. So
I think you have to be
osteoporosis.
careful. I don't think you can say that because there isn't actually large research studies that tell us that taking hormones prevents heart disease. There are smaller studies that show that if you start hormones close to the time of your menopause and you continue on them, that yes, there is less of a development of plaques, which is measured by the measurement of thickness of the wall of the blood vessels going to the brain. I'm at the hospital.
Yeah, sure.
For patient description, upon completion of the search of your area, submit your search report online or by calling extension 5055.
But we also know that, again, the longer you're on hormones for, the higher your risk of other diseases is to happen, such as breast cancer, such as developing a blood clot. So I would not say that we have the evidence to tell us that hormones prevent heart disease. We actually have evidence to the contrary, that for older women who start hormones, they have more heart disease, and that for younger women who start hormones, they don't have more heart disease. But we can't say that hormones prevent heart disease yet. We can definitely say that hormones prevent osteoporosis because estrogen is a very potent drug for the bones.
Yes.
It helps to prevent bone loss from happening, and it can be used as a bone treatment. It would be, I would say, premature to say estrogen is important to keep you young or to prevent Alzheimer's. We don't have evidence to tell us that either. We have evidence that younger women who go through menopause prematurely, when they wouldn't have gone through menopause otherwise, or if they're under 40 when they go through menopause, those women definitely stand to benefit from taking hormones at least until the average age of menopause. But we also have studies, again, like the WHI, which suggested an increased risk of Alzheimer's disease in older women who start hormone therapy.
Yeah.
So there was a lot of conflicting evidence, and I am a big hormone prescriber, obviously. I think that the women who benefit from hormones should stay on them as long as they need them for, but I wouldn't want to say, yeah, you should take hormones for prevention other than for bone loss, because we really don't have the evidence to tell us that.
Okay, great. Thank you so much. So I'll jump to the question though. How can I determine if I need HRT? What tests and symptoms are the key indicators?
So again, the primary symptom for using HRT would be hot flashes and night sweats, but guidelines that come from the organization like the International Menopause Society are a little bit more liberal than guidelines that come out of Canada or America. And they say that menopause-associated symptoms like brain fog and cognitive problems and sleep problems and mood changes may benefit from using hormones. Certainly what we call the musculoskeletal syndrome of menopause, which is wasting muscles, aching joints, arthritis. This can also benefit from estrogen therapy, tendinitis, tendinopathy. So there are lots of menopause-specific symptoms that do benefit from the use of hormones, but it's not to say that everybody who is going through menopause, let's say who has no symptoms, should go on hormone therapy. So there isn't a blood test that tells you you should go on hormone therapy unless, again, you're under 40 and going through menopause inappropriately. If you're going through menopause at a normal time in your life, and this is a natural menopause, it's not from surgery or from chemotherapy or radiation therapy, then I would go by your symptoms. And if you have a symptom that is new, that is bothering you, and that is related to menopause, then there's a good chance you will benefit from using hormone therapy.
Okay. So the next question is, what are the main types of HRT and how do they differ? Which hormones are used, like estrogen, progesterone, testosterone? what forms, pills, patches, gels, injections, and is there available injectable forms of estrogen and testosterone in Ontario?
Yeah. So in Canada, we have pills of estrogen. We have estrogen that can be delivered through the skin with patches or with gels. Progestogens are another type of hormone that are primarily used to protect the lining of the uterus from becoming overgrown and cancerous when estrogen is taken. And there are certain progesterones that have some additional benefit that help with feeling more calm or falling asleep. That is not primarily what they're used for. They are used for protection of the lining of the uterus. So if a woman is suffering from menopausal symptoms, she needs to usually go on estrogen for most of those symptom relief. And the estrogen can be by mouth, by patch, or by pill or by gel. If she has a uterus, then she should also be taking a uterine protective agent. And for the most part, that's going to be something from the family of progestogens. And within progestogens, we have micronized progesterone, which is the same progesterone that your ovary makes after ovulation. That can only be taken by mouth or vaginally. If somebody is giving you progesterone to rub into your skin, you are not getting enough progesterone because it doesn't absorb well through the skin. Synthetic progestins can also be taken by mouth or in the uterus or through the skin because it's a different product, but they are not as good for you from a breast cancer risk perspective or from a blood clot perspective. Testosterone, there is not an approved product for women in Canada or in most countries around the world, but we know that there is value for a lot of women in using testosterone, primarily for low libido in menopause. But some women also anecdotally will say they feel better from a cognitive, energy, muscle building perspective. So when we use testosterone, we use it through the skin, also as a gel. We take a product that's on label for men and we use it at a reduced dose for women. But because the side effects can be permanent and can be quite negative, like your voice changing like a man or growth of your clitoris to look like a small penis if you use too much of it, it is important that your blood levels be monitored to make sure that you stay within the lab's target range for being premenopausal. So that's what the target would typically be. There are no injectables that are recommended in Canada for the treatment of menopause. So there are certain injectable progestins you can use. Sometimes those are used in fertility treatment, but in general, things like pellets or injectable estrogen, progestins, or testosterones are not recommended. They are not Health Canada approved. And even though they're available in America, they are also not recommended by the FDA or by the Menopause Society, who write some of the guidelines and make big statements on menopause because they are not evidence-based. It's very hard to know what the benefits are, what the risks are, how long they take to show an effect, how long they last in your body, right? It's like injecting yourself with some unknown product and saying, well, I feel good, so I'm just going to keep using it. So I'd really caution against the use of pellets or injectables.
Okay, and following that, how often, when you start the HRT, how often should you test your blood or whatever the level of hormones? And
So usually,
which types of tests can you provide? I know that there are a lot of like blood tests. There is a uterine test. There is a dry uterine test. There is a saliva test. So which one is more informatable, and which one you can provide in Ontario?
yeah, so in general, the tests that you're paying for, like a urine Dutch test, these are, or a sweat test or a saliva test, these are really not going to be helpful or evidence-based. They're going to maybe tell you things that may or may not actually be important, usually not important. But it seems to me like a lot of people, they just want any information they can get. So they feel very reassured by collecting this information. But again, it's something I'd caution against because it's not validated, it's not studied properly, and it doesn't really tell you important information. What's important is this healthy for me? Am I on the right dose? Do I feel better? Is there risk here? And for that, blood levels are the most useful in certain circumstances. So it is not very useful to test the blood for estrogen or for progestins because they don't change your blood levels in a way that is really measurable because of the way oral pills are metabolized. They don't get measured in the same way of the type of compound that they are. You can measure estradiol levels in women who are taking patches or gels. And sometimes this is helpful if, for example, you have a patient on treatment and you can't really tell why they're not responding. Is this someone who isn't absorbing well? Is she getting side effects because she's absorbing more than I expected her to? Why is she having bleeding? Is she not absorbing enough estrogen or is it too much? This is where an estradiol blood test can be helpful. But it's not really helpful if you are on a dose, you are having no side effects, your symptoms are well controlled, because we don't want to go by the blood level. We want to go by how you feel. And if I test your blood and you're doing really well on a dose of a patch, let's say, and the patch tells me she's actually on too much estrogen, she's absorbing too much, but this is the dose that works for you to control your symptoms, am I now supposed to take you off of the estrogen that you're on and say, well, the blood test told me to? I would much rather go by your symptoms and have you feel your best than be trying to target some unknown level, which is really not based on anything. On the other hand, testosterone should be leveled because if you check the blood, you know that the patient is staying within a safe range, protecting them from those irreversible side effects.
So the best advice for women, I guess, to be their own wizard and to feel and listen to your body and how you react. So you listen to your symptoms, because you know, the
100%.
best whatever you can bring to your doctor and work with on your health. So it's your own symptoms. So
Your
maybe it's
symptoms are the
better to
most
write a
important part.
journal.
Yeah. Going by symptoms in menopause is the most important part. We care about your symptoms. We want to treat your symptoms. It's possible that there isn't one solution for all of your symptoms. And that's why in my practice, I think it's very important to prioritize symptoms and say, what is going to make the most difference in your quality of life? So that is what we're going to target first. And if we fix that problem, whether it's the hot flashes or the sleep or the mood, then we can reevaluate what your problems are and add in more treatment if you need it at that point. But I really don't like starting somebody on 10 different treatments all at once. Here's a sleeping pill, here's a mood pill, here's estrogen, here's progesterone, here's testosterone, because then you really don't know what's doing what.
Yes,
You don't know
exactly.
what's causing what side effect, right?
Yes. Okay. And about the side effects, what kind of side effects are expectable or most common for women? Or is it can be divided in as common, or uh, just everybody feels different?
Everybody is different, but there are some common side effects. So with estrogen, the most common side effects are going to be breast tenderness, because the breast density actually does change with most estrogens and can cause breast tenderness and breast growth. Some women feel nauseous when they take estrogen. Those are the more common side effects. Some women get headaches. Progesterone is what gets made when you are ovulating. So for some women, being on progesterone causes them to feel like they have PMS. It might also cause breast tenderness. It might cause more reflux, like gastroesophageal reflux, because of the smooth muscle relaxation. Some women even have allergic reactions to using estrogen and progesterone because it causes a histamine release. So this is quite common as well. Testosterone side effects would be oily skin and acne. You can get hair growth where you apply the testosterone gel. And the more concerning irreversible side effects would be the clitoral growth, and male pattern hair loss, and voice deepening, because in the right doses, taking testosterone would be what somebody takes if they were transitioning to become a trans male. So we really do have to be quite cautious with the testosterone. Many women don't have any side effects at all to their hormone therapy, and what they're really looking for is relief of their symptoms.
Yes, exactly. I remember how my symptoms started. It's just like all at once. I couldn't get up from my bed, and just all my joints were aching. I couldn't think. I couldn't sleep. I was completely forgetting whatever I was trying to say, and it just boom. I just don't remember what's going on. So that was horrible. So yes, I'm big advocate for the hormone replacement therapy, because it just gives you a completely different life. Okay, thank
For
you
sure,
so
yeah.
much. Yeah, so we are moving to another question. So what the side risk, yes, side effects and risk, we already answered that. So how long should it take in? And we already answered that. Another question, is it possible or necessary to start HRT if you are already in menopause? How can you know if the therapy is right for you personally?
So again, I think that goes back to your symptoms. So if you're already in menopause, perhaps it's been a few years since your last period and you're struggling with symptoms of menopause like hot flashes or night sweats, as well as some of the more subtle symptoms. So the studies tell us that estrogen doesn't really help mood once women are already in menopause, but I think these symptoms are very interrelated, where if you're not sleeping well, maybe this will cause your mood to be low. If you have pain with intercourse or low libido and you feel that your relationship is in trouble, this may cause your mood to be poor. So I would still go by the symptoms. Joint pains, arthritis, your heart racing, vaginal dryness, the hot flashes, the night sweats. These are the common symptoms of menopause that can be treated with hormone therapy, and they may help some of the other cascade of symptoms that occur because you are suffering with menopausal symptoms.
Okay, thank you so much. I'll take it to consideration. Yeah, it's very important. So another question is a very specific one for one person, the women who had already breast cancer. And I received several questions from women who are survivors from the breast cancer. So, and before that, I want to take your opinion on bioidentical hormones. What do you think of them? What's the synthetic and bioidentical? Well, what do you think of them?
Sure. So I think when it comes to bioidentical, it's really important that we all are talking the same language. So bioidentical should mean chemically identical to what the ovary makes.
Sure, yes.
Those hormones are going to be hormones that are available by prescription, pharmaceutical grade, Health Canada approved. That's going to be products like an estradiol patch or gel and a micronized progesterone. So that is chemically identical to what the ovary was making. So it's bioidentical. But bioidentical has sort of taken on its own meaning where it started to mean prescription compounded therapies, which are touted to be individualized, safer, and those kinds of claims are not really based in any evidence. The problem with the compounded therapies, where other therapies exist, because sometimes a compounded therapy is your only option for somebody who has an allergy to something that's in one of the, pharmaceutical grade
Yes.
products, kind of. But where an alternative exists, if you are compounding therapies in the hopes that you're going to be getting a more individualized approach, there are quality control problems between one batch and another. So they don't have the same concentrations, they have different additives potentially. It's very hard to know what you're getting from batch to batch. And because you don't know exactly what you're getting, it's also hard to know what the risks and the benefits are. People tend to feel very good when they take hormone therapy because they benefit from being on the estrogen. But it's not to say that it's safer or better to be on something compounded than something that is chemically identical to what your ovary made, but still produced from a pharmaceutical where there are strict quality control measures that go into the formulation. So I believe that bioidenticals, in the sense that they're chemically similar to what your ovary made, can be very well tolerated. They've got good safety profiles. People like the idea that they're more natural, so that part is great. But I would still suggest, if you can, to get them from any pharmacy. Let your insurance cover it if you have it, rather than believing that something compounded is safer, because that's really based on anything.
Okay, great. Thank you so much. So I'm moving to that specific question regarding the breast cancer. Can bioidentical hormone therapy be considered for women who had triple negative breast cancer, which is not hormone receptor positive? For example, I had triple negative breast cancer 20 years ago. I was tested for a number of genetic mutations related to breast cancer and none were found. However, doctors are still afraid to prescribe any kind of bioidentical hormones during perimenopause. I'm experiencing severe perimenopause symptoms like insomnia, hot flashes, headache, and brain fog. I'm taking supplements, but nothing really helps. I would really like to hear the doctor's opinion on this.
Yeah, so these are great questions. And I think if we sort of rewind and take a step back, it's important to first understand why should women who have had breast cancer be wary of taking hormones? And that's true for any woman with breast cancer, whether it's hormone receptor positive or not. So when women with a history of breast cancer were studied again in randomized control trials, taking estrogen and synthetic progestins, which are worse for the breast, there was an increased risk of breast cancer recurrence found. And this was true for the hormone receptor positive women, but it was also found in higher than expected rates in the triple negative group. So it's not clear that if you're triple negative that you can take hormones, because we still saw an elevated risk of recurrence in the triple negative group after hormone therapies were given. Now, that's true because those recurrences came within the same breast or the opposite breast. We have no idea that if you had breast cancer 20 years ago, perhaps if you had a double mastectomy and you've not had a recurrence in the last 20 years, while you were making all of your own hormones throughout your menstrual cycles, what is the risk of giving you hormones? That has never been studied, and it probably never will be studied in a very rigorous way because these are less common scenarios. It's hard to find women, and we already are worried about the risk. That being said, if you are suffering from symptoms, you are 20 years out, and especially if you've had a double mastectomy, and I don't know if this person did or did not.
Yeah, I didn't. Yeah, she didn't tell us. Yeah.
Yeah, then presumably your risk of recurrence is fairly low. You've been exposed to cyclic levels of estradiol and progesterone for the last 20 years, once your periods came back after chemotherapy, and you haven't had a recurrence since then. Arguably, your risk of recurrence from starting hormone therapy now is quite low. And there was a recent meta analysis and systematic review that gave recommendations on using hormone therapy after breast cancer, which mostly said if it's hormone positive, use caution or don't use hormones. And if it's hormone receptor negative, it may be okay in certain circumstances. I would think that this is one of those circumstances where it could be considered, but you have to go in with your eyes wide open saying, I don't really know what this will do for my risk of recurrence. And you have to accept that that is a bit of an unknown risk. There was one study called the Liberate trial, which looked at the use of a medication called Tibolone, which is now available in Canada and has been available in Europe for the last 30 years, where they gave women this product, which gets metabolized into estrogen, progestin, and testosterone. And they found no increased risk of recurrence in the triple negative survivors, but it was only for a year of use. So I think if you're going to consider hormone therapy, there are sort of three regimens which may be most appropriate. Tibolone is one because you have that short-term data. Using estradiol through the skin with cyclic progesterone is another because that emulates your menstrual cycle that you've been having for the last 20 years. And the third is a combination medication called Duaviv, which is conjugated estrogen with basidoxifene. The basidoxifene is a hormone blocker in the breast, and it does not increase breast density. It is associated with lower breast cancer rates, and very recent randomized control trial shows that it actually shrinks ductal carcinoma in situ. So those would be the three options I would consider if you were going the hormone therapy route. If you were not and you wanted to treat the hot flashes and night sweats, using a neurokinin 3 antagonist like fezolinetant would be a probably overall safer option.
So you right now give us such a specific directions for that lady and for women who had the same situation. The next question then, who can prescribe those medicine for those women? Because I think that if doctors are hesitant to do that, so it's probably will be a huge lineup to your office to get those prescriptions.
100%.
So yeah, can you advise where to go, what to do, what to ask?
Yeah, and this is an access problem in Canada. There are very few menopause specialists. We all have very, very long wait lists. My wait list is about 2.5 years for seeing women who are average risk with menopause problems. And for that reason, I actually started a private clinic called Coven. The website is www.covenhealth.com, COVENHEALTH.com. This is a clinic that I designed. It's a program that I designed, and we've got nurse practitioners, dietitians, psychotherapists, social worker who are able to offer a collaborative and multidisciplinary approach to giving evidence-based menopause management. And it's outside of provincial insurance so that women can get access to these I think very important services in a way that is a little bit more individualized and multidisciplinary, that attends to all of their needs. Because even for things like, should I take hormone therapy after breast cancer? There are dietitian responses that are important. There is a social worker who may be able to help you with some of the mood issues or dealing with the hot flashes with cognitive behavioral therapy. So putting this program together was very important to me as a way to help women access evidence-based care in a way that is scalable and not just waiting 2 years to see me in the office.
Okay, great. So this is your project that you wanted to mention, right?
Yes,
Okay,
absolutely.
so yeah. Okay, so everybody, ladies, just go to that website. We'll provide the link for the website, and you will get the information and valuable resources and whatever there is on that website to help you to get better in your health and to stay healthier.
Yeah, because the problem with waiting for a menopause specialist is you will wait a long time. But in a scenario like I've had breast cancer, should I take hormone therapy? This is fairly outside of the scope of your average family doctor.
Yes.
Already family doctors are trying to learn, because they haven't learned for 20 years, how do I prescribe hormone therapy even for the healthiest, most appropriate candidate? So when it
Yes.
gets nuanced, it becomes much harder, and it's not fair to expect the family doctors to know how to make those kinds of decisions.
Yes, and exactly. And the physicians and doctors, they are just basically don't have that studying that much information. So they just have a little course for 12, 14 hours about menopause, and then go to a different their specializing area, right? And it's just lack of knowledge. So they just don't, not because they don't want to, but they just don't have it.
I think some of them may not want to, but they really, for the ones who do want, they have to work very hard at learning something that was never taught to them properly.
Yeah, I agree. Absolutely agree. Okay, so we are giving our hope, and yeah, so everybody goes to Dr. Jacobson website. Okay, so next question. Contradictions, family history of female cancer or personal history of cancer. If I have a hormonal IUD, can it be combined with HRT?
Yeah, so those are, again, different questions. So the second one is a bit simpler. If you have a progestin-containing IUD like a Mirena, it can absolutely be used as the progestin component of the hormone therapy. You can add estrogen on top. This is a very nice transition into menopause through perimenopause, because the IUD helps with heavy bleeding, the IUD helps with birth control, and it acts as that endometrial protective agent for hormone therapy. The first question was, what if I have a family history of cancers?
Yeah.
A family history of cancer is not a reason to avoid hormone therapy, but it is a reason to try and understand what is your risk of, let's say, breast cancer. Or of gynecologic cancer, because there are certain genetic mutations that run through families that predispose to getting certain cancers. So if you have a strong family history of breast cancer, uterine cancer, colon cancer, ovarian cancer, pancreatic, gallbladder, these are reasons to talk to a genetic counselor and see if you qualify for getting genetic testing within your province to know if you are at risk for those diseases, but also to calculate your breast cancer risk to understand if you qualify for high-risk breast screening, which might mean an MRI, ultrasounds, rather than just mammograms once every other year. However, just a family history of cancers is not a reason to avoid hormone therapy. You would not have a contraindication unless you yourself had a personal history of breast cancer. Similarly, certain gynecologic cancers, if you've had, let's say, an advanced endometrial cancer or certain types of ovarian cancer, you might want to avoid hormone therapy. But there are many types of gynecologic cancer where it is safe and studied to give hormone therapy afterwards.
Okay, great. Thank you so much. So I'm moving to another question. My mother developed polyps, fibroids after HRT. Is it still a concern today? And what age is it considered too late to start HRT, which you already answered a little bit?
Yeah, so polyps and fibroids are both usually benign and hormone sensitive. So it's very possible if you start HRT, you might grow new polyps, or if you already have a fibroid, the fibroid might grow depending on the dose of hormones that you're taking. In general, these are only a problem if they're causing you a bothersome symptom. So women may only find out that they have a polyp because they start to have abnormal bleeding after menopause, in which case they need some investigations to understand why that's happening, and you will identify the polyp. But if you think you have fibroids or you know you have fibroids and you start hormone therapy and nothing changes, you don't have to go looking for a problem.
Okay, great. Thank you so much. And we are moving very fast to the end of our session. So I don't want to hold you so much, but we have 3 more questions in Q&A area. So I want to move for that. First question is, I'm in menopause for 5 months. I do not have major symptoms. Would you recommend HRT for prevention? For example, for prevention of osteoporosis, heart problems, brain fog, cholesterol increase, insomnia, weight gain, and so on. Thank you.
So if you are 5 months without a period, technically you're not yet in menopause. Maybe you've been a year without a menopause plus without a period plus 5 months, then you actually are in menopause. Usually people are getting symptoms by the time they're about a year without a period. So if that's you, you would usually know if you already have symptoms of menopause, except for vaginal dryness and those vaginal problems, which do develop later. If you are having no symptoms and you are at average risk for osteoporosis, there probably is not a role to start hormone therapy just because you're in menopause. There's, as I said before, not enough information to tell us that there is benefit and not risk. And for every study that shows benefit, there is one that shows risk from a cognition point of view. But if you are suffering from brain fog or some of the less common symptoms of menopause and you're wondering, will hormone therapy help me? It's certainly worth a try if you don't have a reason to avoid it.
Okay, thank you so much. Okay, so moving to another questions. Do you accept new patients? The problem is that my case is quite complicated for ordinary obstetricians. I would receive your personal consultation.
Yeah, so I would be happy to see anybody in my office. It's just a long wait.
Yeah,
But if you
in
want to know that you're
2 year and a half, yeah.
yeah. But if you want to see the nurse practitioners who are under my direction much faster, you are absolutely welcome to be seen at Coven and you will get the same care.
Okay. Okay, so another question. Is it mandatory to monitor your breast while you are on HRT?
So it's never mandatory to do anything. It is important to do breast screening in general, based on, again, your own risk, which can be calculated, and your provincial guidelines. So in Ontario, we start breast screening now at age 40, and for average risk women, it would be every other year. But we also are now reporting breast density. So if you have dense breasts, for example, category C or D, you might be offered mammograms once a year. And because hormone therapy does increase breast density for most types of hormone therapy, it does in an indirect way and long term increase your risk for breast cancer at a small level. So I would suggest getting breast screening because breast screening does work at finding breast cancer early, in which case you will have better survival, of course, and better treatment. But nothing is mandatory and you don't have to do anything differently just because you're on hormone therapy.
Okay. Okay, so I guess we don't have, oh no, there is another question. Okay. Okay, so can we request breast ultrasound instead of mammogram for breast screening?
Technically, no. Breast ultrasound is used to help further understand a lesion that can be seen or felt, but it's not a good screening tool. A screening tool needs to be able to look at the entire breast efficiently, and ultrasound is much better for targeted lesions that you're trying to look at.
Okay, great. Thank you so much. So while we'll be waiting for another questions, I have a lot to go on. So another question. Early menopause, can it be managed?
Yeah, so early menopause means menopause under age 45, and premature ovarian insufficiency is under age 40. Both of these, if even if women are not symptomatic, they should be offered hormone therapy because they are at higher risk for Alzheimer's disease, osteoporosis, and early heart disease. So for these women, again, if they don't have a reason to avoid hormone therapy, they should be offered hormone therapy even if they don't have bothersome symptoms.
Mm-hmm. Mm-hmm. Okay. Okay. So that's good to know because in my group I have a lot of question about early menopause and how to manage it and what to do if you are 35, for example. Another question is again about early menopause. I have early menopause since age 35. I'm now 43. HRT triggered fibroid growth. I now feel estrogen deficiency, poor sleep, joint pain, dryness, low libido. What can I take to improve my conditions?
So in that case, I would still probably suggest hormone therapy. There may be a better regimen that helps, that doesn't cause as much fibroid growth, or you can have the fibroids dealt with by cutting off the blood supply with an interventional radiology procedure or a surgery so that you can continue to take the hormone therapy for your long-term health and well-being. But if a fibroid grows a little bit in response to hormone therapy and it's not causing a very bothersome symptom, I would not let that be the thing that stops me from using hormone therapy.
Okay. So yeah, you sound like it's not very bothersome for for you or for should be for ladies to take hormone therapy. So it's much safer than everybody else is thinking of it.
Yeah, I think for people who don't have reasons to avoid hormone therapy and have benefit to be gained from using it, there are lots of regimens out there and there are lots of ways to prescribe hormone therapy safely to improve your quality of life and your long-term health. But that doesn't mean you should take it for prevention, and it doesn't mean everybody should be on it.
Yes. So in that, following that point, that so what tests should we take before starting HRT therapy? Because we need to find out if we have any inherited problems or I don't know whatever we developed for that age already, like liver problem or I don't know fibroids, endometriosis or whatever, some lump in breasts or something, cysts. So what do we do? What do we start with?
So there is no test that is mandatory to do before starting hormone therapy if somebody has no complaint. So if you have no abnormal bleeding, maybe you've been menopausal for 2 years, there's no bleeding, you don't have to do an ultrasound to make sure that there's not a problem before you start hormone therapy. For the breasts, ideally, you would want to have had your breast screening done within the last 2 years because that is the breast screening interval, but you don't have to do an extra mammogram in order to start hormone therapy. They're independent of each other. If new problems develop when you start hormone therapy, they can be looked for.
That's interesting because everybody wants to prevent diseases and prevent developing some like worse conditions, but it doesn't require any test before HRT. That's really I don't know. For me, it's strange and not understandable because for myself, I would go all through like blood test, ultrasound, mammogram, but every test I could have hold on, I would do that. So why is it not necessary then? Is it does it relate somehow to hormone replacement therapy or I don't know. So why is not required? Can you
Again, I
explain
think
it a little bit?
because if somebody who is otherwise healthy is looking for a problem, they might find one, but it may or may not have any relation to starting
Okay.
hormone therapy.
Uh-huh. Okay.
Right? So
Okay.
there are certain hormone therapies that require, not hormone therapies, but menopause treatments that do require or screening, like
Mm-hmm.
going on Veoza, for example, which is fezolinetant. Health Canada says we must check the liver enzymes. But
Mhm.
if you are just starting estrogen, progesterone, you're an average age for menopause, you don't have major medical problems, you don't have to start doing blood tests or mammograms or ultrasounds in order to get a pass to start the hormone therapy.
Okay. 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 I got it. Okay. I got it. Okay. Thank you very much for that. And I guess we have two more questions maybe. Um, I'm on HRT. My thyroid tests are within normal range, but I still have symptoms. Why?
I mean, I'm not a thyroid specialist. There are certainly some women who feel better when their thyroid is more tightly controlled.
Yep. Okay, here you are.
So the thyroid, though, it can become impacted by menopause. Some women find they have to increase their thyroid replacement when
Mhm.
they are now menopausal. And also oral estrogen can cause the TSH to not be as well controlled. So
Mhm.
sometimes you need to change your thyroid dosing when you go through menopause or when you start certain hormone therapies.
Okay. I got it. Thank you so much. And another question I have, at 46, should I get Mirena IUD or something else for contraception? How does that fit with perimenopause?
So I really like the use of the Mirena IUD in perimenopause because of the reasons we talked about before. It gives you
Mhm.
contraception, it helps with heavy bleeding, which is quite common in perimenopause, and it allows you to transition into menopause if you start to have symptoms by giving you the opportunity to add estrogen on top of it. It is not the only option. So if you are looking for contraception and you're perimenopausal, you could also use certain birth control pills. You could use progesterone only birth control pills, which also allow you to add estrogen on top of them. You can use a copper IUD, which gives you very heavy periods but has no hormones. So it really depends on what your individual goals are. But the Mirena is a great option in perimenopause.
Yes, that's what I've heard and I read about that a lot. So yeah, Mirena is a very good option for contraception. So I have another question in Q&A area. So what is the other more healthier way for breast screening?
I don't know what that means. I would say like a mammogram for an average risk patient is
Mhm.
an appropriate way, and certain mammography places will also use sort of additional ways of looking at a mammogram that make it a little bit more sensitive. If they see something, they will go on and use an ultrasound or get an MRI. And for women who are high risk, so their baseline breast cancer risk is more than 25%, which you could determine from a breast cancer risk calculator, they would qualify in many provinces for mammograms and MRIs on an annual basis.
Yeah, I guess that the question was about this MRI, breast screening mammogram, that it's more harmful for breasts and it's not very easy process to do. So I guess this is what was the question. So the more safer for the breast and for yeah.
I mean, mammograms are not supposed to be dangerous. They are definitely uncomfortable, but
Yes.
they are not a dangerous way of having screening, and they do work. If there was a way that you could access an MRI by private pay, by going to the States, MRI is excellent for breast screening and doesn't have the same discomfort or radiation.
Okay. Okay. Thank you so much, Dr. Jacobson, Dr. Michelle Jacobson. I'm so happy to have you here. So we have a couple of minutes before we wrap up. Do you want to say something? And your just last words for our ladies.
Just, I think be in tune with your symptoms. If you go on the Menopause Foundation of Canada, they have a symptom tracker, which can really help you to be aware of what symptoms can be from menopause and which are not. Know that you are not alone. I think it's so wonderful that you've got a podcast like this and a Facebook groups, Svetlana, so that you have a place to go to access good information. And if you are looking for care and you want to access it more quickly, certainly Coven is a good resource for you. And most of your care at Coven can be submitted to private insurance. So if that's a concern, I'm very hopeful that Coven is an answer to so much of the access issue that we see for menopause care.
Okay, great. So when I will be sending recording to our attendees, I will add the address for your website and for your project and everything, so they can find it easily and be, you know, in your service.
Perfect. That's what we want. Join the Coven. Svetlana, thank you so much for
Okay.
having me on. It was a pleasure.
Thank you so much, Dr. Michelle. And I think that we have not covered just maybe a tiny bit of the questions, so it might be recurring webinar. And yeah, I will be happy to have you again.
Perfect. It was my pleasure. Nice to meet you.
Thank you. Thank you so much. Okay.
Bye.
Yeah, bye-bye.